Welcome to ASAP UAE Prometric Coaching for General Practitioners. Let's begin the session with a question. A female patient diagnosed with major depression complains of excessive thirst and urination. She has CA breast with lung mets. Investigation shows hyponatremia and low urine osmolality. What is the diagnosis? The options are A. Siadh, B. Diabetes insipidus, C. Psychogenic polydipsia. To solve this question, we need to know about normal ADH secretion and its abnormalities. As we all know, ADH is synthesized in the hypothalamus and is stored in posterior pituitary gland. The ADH released from the posterior pituitary acts on V2 receptors in the kidney, leading to water reabsorption through aquaporin 2 channels. As a result, we get concentrated urine. This is the normal physiology. Now moving on to SIADH or Syndrome of Inappropriate ADH Secretion. Here, as the name suggests, there is inappropriate ADH secretion leading to more ADH acting on V2 receptors and resulting in more water reabsorption. Therefore, the urine is more and more concentrated. So when we look into urine osmolality and urine sodium, they both are increased. At the same time, what happens inside the body is there is hyponatremia and decrease in serum osmolality. Now, what causes this ADH secretion? Or in other words, what are the causes of SIADH? One of the most common cause is a lung malignancy, that is small cell carcinoma lung, or it could be due to certain drugs like carbamazepine, SSRIs, amitriptyline, morphine, etc. The other causes are CNS pathology like meningitis, subarachnoid hemorrhage, infective causes like pneumonia, cerebral abscess, or in cases of hypothyroidism. The treatment of SIADH includes antagonists of ADH like tolvaptan and conivaptan. They are used in urgent therapy for severe symptomatic SIADH. And we know that SIADH can also be from an underlying disorder which cannot be corrected, like a metastatic cancer. So in this case, demiclocycline comes into action. It blocks the ADH at the collecting duct of the kidney tubule. Moving on to diabetes insipidus, there are two types of DI, that is central and nephrogenic. In central DI, the ADH synthesis and release is affected, while in nephrogenic DI, the action of ADH on the kidneys are affected. So in both cases, the water reabsorption does not happen and we get a dilute urine. Thus, the urine osmolality also is decreased. Central diabetes insipidus results from any destruction of the brain from stroke, tumor, trauma, hypoxia, or infiltration of the gland from sarcoidosis or infection. In case of nephrogenic DI, chronic pyelonephritis, amyloidosis, myeloma, or sickle cell disease can damage the kidney enough to inhibit the effect of ADH. And more commonly in the question, it may be mentioned the use of lithium or demiclocycline. Moving on to the treatment part, central DI is treated with long-term vasopressin or desmopressin use, while nephrogenic DI is managed by trying to correct the underlying cause if anyone is present, like hypokalemia or hypercalcemia. It also responds to hydrochlorothiazide, amiloride, and prostaglandin inhibitors such as NSAIDs, example indomethacin. A patient with diabetes insipidus presents with excessive thirst, and when we look into the investigations, urine volume is increased while urine osmolality and urine sodium concentration is decreased. The opposite happens in serum, that is, serum volume is decreased and serum sodium and osmolality is increased. So, in order to distinguish between central and nephrogenic DI, next step is to proceed with vasopressin or desmopressin stimulation test. Now, what is the best initial test we do in a patient who comes with polydipsia? It is a water deprivation test. it is done to distinguish between diabetes insipidus and psychogenic polydipsia. In psychogenic polydipsia, the patient voluntarily takes large amount of water, resulting in dilute urine. So here in this test, when we deprive the patient of water for a certain amount of time, the normal physiology comes into action in the psychogenic polydipsic patient. Means their urine volume decreases and urine osmolality increases. In patients with diabetes insipidus, there is continued high volume and dilute urine because the pathology here is deficiency of ADH, or the ADH is not acting on the kidney. So our next step is to administer ADH and check whether the kidneys are responding to it or not. So when we give ADH from outside, if the urine volume decreases and urine osmolality increases, it is a case of central DI. While if there is continued high volume dilute urine, it is a case of nephrogenic diabetes insipidus. We can remember both these conditions with the help of this figure. In SIADH, SI means soaked inside, and in diabetes insipidus, TI means dry inside. As we discussed before, in psychogenic polydipsia, there is excessive volitional water intake, and it's often seen in patients with psychiatric disorders or neurodevelopmental disorders. So in the question, it will be clearly mentioned about a psychiatric disorder or a neurodevelopmental disorder. Now let's come back to our question. The patient here is diagnosed with major depression who complains of excessive thirst and urination. She has a history of CA breast with lung mets. And the investigation shows hyponatremia and low urine osmolality. What is the diagnosis? Here we may get confused with SIADH because a history of malignancy is given, and psychogenic polydipsia because a history of depression is given. So we can rule out the options one by one with the help of the investigation given. So in SIADH, remember the mnemonic soaked inside, that is the serum sodium is low but there the urine osmolality is high. So option A is ruled out. In diabetes insipidus, the urine osmolality is low and this fits the question, but the serum sodium is high. So this option is also ruled out. Thus the correct answer here is psychogenic polydipsia.